I'd now like to introduce Paul Mulholland from UCLP and Mount Vernon. He's a medical oncologist specialising in brain tumours, and he's going to discuss the role of bevacizumab in glioblastoma.
The role of angiogenesis therapy has been a very intense area of research over the last few years. Avastin was given as a single agent in relapsed glioblastoma and showed very promising results. To date, there has been inadequate evidence to fully support its role in glioblastoma, and 2 registration studies have been established and presented here at ASCO. The first study is the Aglaia Study. This is a Roche-sponsored study that was performed in Europe, and the RTOG 0825 study is a North American study, which we have the data for now. The Aglaia study is examining the role of Avastin in the first-line setting. Approximately 900 patients were randomized into this study in Europe, 450 patients to each arm. The standard treatment for glioblastoma is to have 6 weeks of radiotherapy with concomitant temozolomide, followed by 6 cycles of adjuvant temozolomide. The Aglaia study looked at this schedule with the addition of Avastin in half the patients. The co-primary endpoints for this study were progression-free survival and overall survival. And this slide shows the progression-free survival for this study. We can see that there's been an increase in progression-free survival from 6 months to 10 months. This has been a very exciting result for the brain tumour community. However, the overall survival is disappointing. Questions have been raised about why the overall survival has not been improved. It has been suggested that crossover with patients that relapse getting Avastin is part of the cause for this. The next study that I'd like to discuss is the RTOG 0825 study. This is a first-line study examining the role of bevacizumab in glioblastoma. Again, it's very similar to the Aglaia study in that the patients all had standard chemoradiation followed by adjuvant temozolomide. And again, half the patients also received Avastin. The co-primary endpoints were the same, overall survival and progression-free survival. When we look at the results of this study, they're not quite the same as the first study. In this study, the median overall survival showed no difference with a median overall survival of 16 months for both arms, but the median progression-free survival in this study was 7 months versus 10 months. However, this did not achieve the pre-specified endpoints for the study. So what do the results from these 2 trials mean for people with glioblastoma? Well, they haven't supported the use of bevacizumab in the first-line setting. There certainly is a role for bevacizumab in this condition, but really it's about when. Within all groups of patients, there will be some that do require it in the first line, but really we need to have biomarkers to determine who they are because we don't know how to pick those out. There was conflicting data in the studies on quality of life and neurocognitive function, and there was a suggestion from the North American study that bevacizumab might actually cause a decline in neurocognitive function. I don't think this is the case, and I think that might be related to study design, where patients are actually getting neurological decline because of the disease, and that's why they're declining, but it's not being picked up on imaging. There was a very interesting aspect to the North American study where they perform molecular profiling on the tumours, and they're actually trying to establish biomarkers to be able to predict who would need Avastin in the first-line setting. If they are able to achieve this, then this certainly would be a great move forward for glioblastoma patients, identifying those that really need Avastin first line. Because what we don't want to do is give it to everyone and then find it's not actually going to change survival. So really, these two studies have raised further questions about the role of bevacizumab in glioblastoma and when it should be administered. And we really are going to need to look for a biomarker for this condition to look for when we use Avastin. What's been rather strange for bevacizumab in glioblastoma is that it's always performed as a single agent just as well as when it's been in combination therapy. I don't really have an understanding of why that is, because in other tumour types it performs better when in combination. This could be related to the dose that we're using in brain tumours, and maybe a lower dose of 5 milligrams per kilogram would be more appropriate, so as to allow better perfusion for the other agent to get to the tumour. But overall, I'm very pleased that these two trials have taken place. They've demonstrated that trials of this nature can be conducted in brain tumour patients. They were well conducted, the data has been collected very well, and I'm very encouraged that we'll be able to do good studies with brain tumour patients in the future, and hopefully we'll soon find something that will improve this devastating illness.